Sorry about that, guys. What is it? If I don't have a, see, this is what happens when I adjust the lighting. So if I don't have my phone on auto rotate, it won't, it will not listen to me when I try to do it again. So that's what happened. That's why I had to end the other one, because it wasn't going to let me rotate the screen, and I didn't want to have to hold the camera the whole time. Who's that? Misty? Hi, Misty. Thank you for the blue hearts. I'm waiting for my screen to come up here, which it is. Thank goodness. Now I gotta mute myself, otherwise I'm gonna get playback. All right, I am muted. All right. Okay, so the lighting's not too bad, right, guys? Are you gonna save this video? I save all of my videos. I mean, why else would I do videos? Tabitha, hi, I've been looking forward to the show tonight. Oh, good. Hi, Rebecca, thank you for the blue hearts. You guys sure know how to make me feel welcome after being away from you guys for 4 days, right? Four work days, but it's all right. Hope the lighting is okay. It looks okay on my computer, but I don't want to like turn it, because then it's gonna like be weird and cast weird shadows, and I can't have it like front facing me, because it does weird things too. So I don't know. I know, right? We miss y'all. Thank you, Misty. I appreciate that. It has been a long week, and I'm gonna spare you guys from all of that, but you know, I'm just gonna sit here and enjoy my coffee with all of you, because I made it on time despite having a little bit of a technical hiccup. And I definitely missed you guys too. All right, tonight we are talking about gaining confidence as a new medical coder. This is what happens a lot. And people who have gone through, sometimes they go through like long programs and they still don't get it. But a lot of times people will message me like, Blue, I went through one of these really quick programs before I found you, and I passed my certification exam, but I just don't understand what I'm doing. Can you help me? So we're going to talk about that. We're going to talk about some coping strategies tonight. And so hopefully we can have a really good conversation, because it is Friday night. And I am drinking coffee, freshly brewed. The lady at the front desk, I think she doesn't like me. So I said, can you please make some coffee? She made it. But, you know, oh well. They say they make coffee all day, so I'm okay. Okay. And I wasn't the only one looking for coffee. I will just say that. The coffee that they did have was ice cold. And I'm like, no. I need new coffee. Can you make some? She's like, okay. Johanna, I love all your videos. I like to learn. I think you meant. Yes, thank you so much. Rochelle, hi Blue, ready for this lesson? So interesting. Yes, Tabitha, TGIF, absolutely. And thank you for the blue hearts, Rochelle. I love seeing blue hearts. They make me so happy. All right. So here we go. If you're brand new to my channel, welcome. I am Blue. I'm a medical coder. This is not my normal setup, guys. I am just on location. I'll put it like that. But tonight we are talking about gaining confidence as a brand new medical coder. So many times people will message me and say, Blue, I have passed my certification exam, but I feel like that's all the school taught me how to do was pass the certification exam. I don't know how to code. I don't know what I'm doing. What did I get myself into? So a lot of this is going to be having to go through the actual process of actually being in a clinic and actually starting to get experience. And that's not going to happen until you get into the field, which If you watched Wednesday's episode, I talked about applying with a temp agency to help you get your foot in the door. You know, getting assigned to a temp assignment, well, that may not be what you want in the beginning. It will help you because of the simple fact that this is a job that you can put, and this experience can go right on your resume. So don't ever foo-foo the temp agencies. They are a great place for brand new medical coders to start. You can get lots of experience working in different places. The thing about temp assignments is these people know that you're a temp. They're not really expecting a lot out of you. So this is the best time for you to learn and put forth that good effort. Now, when you're telling me, well, Blue, I don't know what I'm doing. I passed my certification, but I don't know what I'm doing. This is going to take a little bit of self-discipline, and self-discipline being that you got to go back to those books again, your workbooks, because everybody gets workbooks in their programs. I've very rarely heard of anybody not getting a workbook with their medical coding program. Those workbooks need to be worked back over. However fast you went through your program does not mean that you have to stop looking at those books. Getting familiar with your medical coding manuals is the start. It is the start of it all. I have been telling y'all to make sure that you read your medical coding guidelines. Reading your medical coding guidelines is so important because that is going to teach you. The thing with medical coding is a lot of it is self-taught. So much of it is self-taught. Well, Blue, I need to learn in a classroom. That would be ideal. Ideal because we have a huge responsibility as medical coders. We have to know what doctors know while never having gone to medical school. And we're self-teaching ourselves to do this stuff. So you're going to have people who have different knowledge bases and different ideas and different understandings and things like that. So this is why you have to make sure that going back through those guidelines is your first line of defense. Understanding them, but not memorizing them because they do get updated. Case in point, the 2020 ICD-10-CM coding guidelines versus the 2021 ICD-10-CM coding guidelines. There was a huge update. Why? Because of COVID. So there's a lot of things that happen in the year, right? And sometimes we get a lot of really good updates, and sometimes it's just like, meh. You know, it's okay. It's a lot of the same, but you never know. So getting familiar with your guidelines is first, and that's going to get you confident because nobody can take that knowledge away from you. Nobody can say, well, you know, it's this, and we're veteran coders, so we know. But actually, if you're reading the coding guidelines and the guidelines have been updated and a veteran coder says, oh no, it's this way, and they have not been looking at the coding guidelines like they should, then you can get that confidence like, hey, I know something. This is where it's going to start. And it's very easy, guys. People ask me, well, what do you do? Read. You read and research. Read and research. When I tell people to research, because they will ask me very simple questions that can be answered through Google. What is the difference between ICD-10-CM and HCPCS? Okay. You knew enough to ask me the question, what is HCPCS and what is ICD-10-CM book? Google. And it's going to be that way when you start learning to do coding as well, because people like veteran coders, you will find some that are going to be very happy to help you. They love brand new medical coders, me being one of them. Who doesn't love a student that wants to learn, right? But there are other medical coders that are veterans that say, no one taught me, so I'm not going to teach you. You're going to have to learn. And a nurse actually told me this is what they call in nursing when nurses eat their young. That's what that means. And I'm like, oh, well, that makes a lot of sense. You know, they're not gonna coddle you. They're gonna throw you in there, and you've got to be ready. You know, and as scary as that sounds, like I said, a lot of what you need to do is that study portion, is that study part. Sometimes the confidence is lacking because you don't understand the language. Medical coding is a completely different language. I've been saying this, and I'm going to keep saying it. I'm going to get a t-shirt made that says it. Medical coding documentation that you got to read is written by somebody who's been to school for at a minimum of 10 years, right? Some go through it 8 years, but minimum 10 years. Let's average, right? 10, to 14 years, somebody has been in school and you got to read that. Not only that, you have to comprehend it. So how do you start to learn to comprehend? How do you start getting that confidence? By research, by understanding the medical terminology and anatomy. I cannot stress the importance of anatomy and medical terminology enough. Why? Because when you're looking at something, how do you know what body part or what location to look in the book if you don't understand where in the body this is? So getting confidence is knowing your medical terminology and anatomy, and that will come with time. But doing your research when you get into your clinic, if you are assigned the cardiac clinic and you start looking at all these cardiac procedures, that is going to help you to learn. It is going to be a totally different thought process, right? Because you have to go through and look at all this stuff and you don't really kind of understand. But the more you put yourself in it, the more that it will come easier to you, but you have to not fear it. You actually have to get into it and start to learn it that way. Reviewing the section of the book that covers your specialty. For example, if you're in the outpatient setting and you're in the cardiac clinic and you need to go over that in the CPT manual, that means you got to go through that section in the CPT manual and read all of the things that are there talking about the heart, you know. You got to be able to read all of that. It's the same thing if you're coding for skin procedures. Now, skin procedures is a huge nemesis, or was a huge nemesis for me. How did I get over that? By actually taking the time to read that section of the CPT manual, looking at all the available procedures. Because when it comes to biopsies and skin grafts and all of those things, excisions of lesions and things, it takes time to learn. But the more you practice with it, the more you'll start to get it. But don't run away from it just because it makes you feel uncomfortable, because you don't get it right away. And that's the thing. People get so impatient with themselves. Oh, I'm never going to get this. Yes, you will. But it's going to take time. It took me 4 years to actually get confident in what I was doing. Was I still doing well? Yes, but it didn't mean that I actually fully grasped everything. That took time. And it wasn't until I had my aha light bulb moment that I was like, oh, okay, now I get it. But when I tell people you got to go through the workbook, you have to work through the word problems, you got to be able to do all those things, they don't want to do it. They just want the answer like, I wish I was more confident. That's how you get confident. You know, how do you think these pro athletes get confident in their ability and their skill? Because they spend the time to work through it. Now, if you went through a very fast-paced program and they just taught you to pass the certification exam, which it is possible, people can be taught just to pass the certification exam and then you're on your own, it doesn't mean that you have to give up. Obviously, you got into it for a reason. So that is something that you need to think about. The next says, a coder's confidence comes with time. I was nervous when I went into inpatient coding, but a seasoned inpatient coder told me even the best medical coders makes mistakes. We are human. Stay abreast of the guidelines, like I just said about reviewing those guidelines. So it is a staple of what we have to do is review those guidelines. And again, knowing what procedures are performed in your clinic is going to go a long way to making you more confident. But that is the only thing that you can be able to do. You don't want to have to spend more money going back through another program. Someone asked me last week, hey Blue, I felt like I was just taught to pass a medical coding certification exam, which I did, but I have no idea what I'm doing. Should I go through a college program and a whole nother program? I have a news flash for some of y'all. Some of those college programs, it's still self-paced. So still having to go through a self-paced thing, you can easily do that for a fraction of the cost by reviewing your coding books again and just rereading them. Finding yourself a mentor with the association when you go to those chapter meetings, or going online to LinkedIn. LinkedIn has a ton of medical coding tutors, And I'm a medical coding tutor myself. My rates will be in the description box below when I update this video. But in LinkedIn, they have tons of medical coding tutors. So you have your choice of whoever you want to help tutor you. And sometimes you may have to pay a little bit more, or whatever. I try to make my rates very reasonable because I know that there's lots of students out there that need help. So I'm not going to charge this crazy amount, but I'm doing it to help you guys. So you can look into that. Sometimes it's easier if you have somebody explain it to you. But what I do in my tutoring sessions is I tell people, I break things down. I don't do assignments. I don't do any of those things. I don't give you guys lessons or anything, because that's not what I do. What I do is explain, this is your problem. You have a problem coding skin. Okay, well, let's review some skin procedures, and let's review some exercises, and then hopefully that will help you to get in a better frame of mind when it comes to those types of things. But you actually have to be the one to get in there and study. It is going to be about studying. There's no shortcut for this, guys. When it comes to learning medical coding and getting confident, you know how many hours I had to do to get confident? And like the next says, there are times when veteran medical coders make mistakes too. I do it. You can ask my boss. She'd be like, oh yeah. But there are times when she has things that, oh, well, wow, okay. And then I'll explain it. Oh, okay, well, that makes sense. So everybody makes mistakes. Everybody does. Even instructors do. Okay, so. Yes, I do, Jackson. Jessica, hi Blue. I have been hesitant about taking a level 2 position coding ED because I was afraid of failing. But I know, as with everything else, it's a matter of studying and learning it over time. Jessica, the best thing about the ER, it is like the Marine Corps of medical coding. Let's look at this. Let's look at this logically, right? Who better to learn than in the ER? You have a plethora of subjects: cardio, neuro, injuries, okay? What is it? Infusions, right? Injections. You've got everything going on. Hydrations, you've got all of that going on in the ER. Mom and baby, you've got that. Pediatrics, you got that. And while, yes, even, family care has a lot of those things, there's nothing quite as exciting as the ER. So the ER has a lot of things rolled into one. I mean, that is one of the best training grounds that any brand new medical coder can have, or any veteran coder really, is working in the ER. Now, when we were tasked at my work, we were tasked to help out in the ER because the ER had a mass exodus of people through no fault of their own, okay? It was because people had retired and some people had moved away. So there was a lot of the ER coders that were gone. So it was all hands on deck. They brought us all in to help in the ER, and we had to code for the ER. Everybody had to code for the ER for 1 whole month. And while I was very irritated that I had to do it, because I like my ortho clinic, I like to be on top of them. I like to make sure that all of their stuff gets coded right away. But when it came to, okay, it's all hands on deck, everybody has to be in there, I was learning. And then at first it was just like, ugh, but then I started to learn. I was like, oh, okay, I got this, and I got this. And of course I got excited when I would see like injuries, and I was like, oh, I got this. Motor vehicle accidents, oh yeah. I was like, give it to me, I got it. And they were like, you're such a nerd, Blue. And then they're like, I'll take like the cough and the cold. I go, give me the injuries. So a temporary vacation. Yes, the ER has everything. So even Kung Fu Ken, even just HCC coding kicks my butt, LOL. So are you not using the encoder, where like a lot of times they'll have like the MCCs and the CCs on there? I've always been curious about that. if using the encoder really does help when you're coding for HCC. That's my question. The next says, because in the ER, the decision to admit to observation, inpatient, or to be sent home is made there. Yes. Yes. And there's a lot of things when it comes to coding in the ER that are unique to coding in the ER. So you have sometimes where you'll have two ENMs, right? Or because like they came in for a car accident in the morning and then they had a heart attack in the evening. That's two different things that are going on, right? So it is so fascinating, just the different combinations of things that can happen. It's just so it'll keep you engaged is basically what I'm trying to say. Yes, Johanna, the ER is the emergency room. Kung Fu Ken, our encoder is basically a glorified book as software. Ooh. Because, there are some really good encoders that talk about, like, okay, this is MCC and this is CC, and mine does that. So it's different encoder softwares, they're going to be different everywhere. And the amount of information that they have can really help. And sometimes it can hinder, like especially if it is just software, Jessica, thank you for giving me your experience with the ED. It definitely sounds fun and interesting to be able to see all the different encounters. Yes, and then when you have ER experience, there's a lot of jobs that'll have, must have ER experience. Okay, great. Well, there you go. But I have heard from somebody who said that that they had a 320, not that yours is going to be like that, but they had a 320 a day quota. And to me, that's something seriously wrong there, because then you're just pushing codes through and you're not really checking for quality. And how can you do that? That's number one. Number two, what are you doing? I know their providers are not that well trained that they can be able to do that. So that is something that is, if the productivity is too high like that, I would just keep looking, because that's going to be a place that's going to have a high turnover, and that would be some place that you would not want to work, because you would not need to stress yourself out. If you take a look at the AHIMA Standards of Ethical Coding, it talks about the absolute need. It's not even a need, it is an absolute, that it is absolutely paramount that accuracy comes first before productivity. So you may want to have to check out those standards of ethical coding. Kung Fu Ken, but it tells you which are HCCs. Wow. Yeah, everybody has different ones. But that HCC is a different one too. I mean, that HCC, people don't really think about this too much, but you have to be really good with the pathology process too, the pathophysiology process of any disease, right? You got to be really good at it, because then you can kind of spot things a little bit easier. So to me, it would be different to do. I would miss the ENM too much, and I would miss the procedure coding too much. So that's why I don't do it. But I thought the ED was 12 an hour. Some places, yes, but that one place that one viewer was telling me is 320. That was the quota for the day, and I said, that's ridiculous. That's not even coding. You're just literally there entering. And I'm like, no. And they were so stressed out and asked me what they should do. Look for another job. There's no reason that, number one, a quota would have to be that high. That's number one. Number two, when you're doing something like that, that's not coding. There's no way you can look at anything if your quota is 320 per day. That is setting people up to fail. Yeah, but in the more reasonable places, right? In my facility, it is 12 per hour. So it's more reasonable there, because it's considered it's like a specialty clinic, even though it's the ER. They do have the ones that are specialty. Ortho is considered specialty. Podiatry is considered specialty. All those, some of the other ones, like Physical therapy is not considered specialty, even though it's physical therapy, but they have a higher quota because it is considered generally easier. But theirs is 15 per hour versus mine at 12 per hour. So it's even though you think, oh, it's only three, so how can that be a huge difference? Trust me. When you're going through them, oh yeah. It'll make a difference and you'll know what I mean. But yes, the confidence is going to take time, folks. I have been a medical coder since 2008. I spent the first 4 years feeling confused. I did. And it wasn't until about 6 years ago, probably 7 years ago now, that I realized that I needed to spend more time devoting myself to actually studying. It wasn't just about, oh, okay, you're going to learn the rules and the guidelines of your clinic. No, it was, I'm going to learn more in depth about what's actually happening so that I can really understand what it is. I learned buccal fracture and torus fracture, that they mean the same thing. And so seeing that and not being confused anymore, I was like, oh yeah, okay, I can explain this. And learning those things. And when you're talking about just certain body parts and what these bones do and the muscles and the tendons and the areas of the shoulder and things like that, it's all so down to the special, right? Because you have two joints, right, in your shoulder, right? You have the major joint, right, and the subacromial, and then you have the AC, the acromoclavicular. And acromoclavicular is considered a medium-sized joint, right, in your shoulder. And then you have your subacromial, which is the major joint. So when you look at those in the CPT manual, when you're looking for an injection code into one of them, right, it's going to change. It's two different locations. So it all goes back to detail. It all goes back to understanding, because a provider can say, well, I did a shoulder injection. Okay, great. Where in the shoulder did you inject? I injected the shoulder, Blue. All right, I understand that. Did you inject into the glenohumeral? Did you inject into the subacromial? Did you inject into the AC? Oh, it was the AC. Okay, good. Now that I know it's the AC, it is a different code. Oh, I didn't know that. Yeah. So you can't just tell me that you're doing a injection into a body part. There's different components that make up that body part, you know. And so that's the thing, you know. When you start to learn more, you will start to be able to ask those questions, and you'll be able to see those things. And that's when the coding will get a lot more sharper and a lot more sophisticated, because you'll really understand what's happening. It's just going to take time to study, guys. That's all it is. And when people ask, well, what are your suggestions on books? The body doesn't change. They haven't discovered any new body parts. All right. They haven't discovered anything new. So any book that you feel would be really good, go with it. Anything about medical terminology, again, we're not coming up with new medical terms, right? They're pretty much all out there. And I've told everybody, and I repeat this, learn your prefixes, your suffixes, and your root words. When you learn those, as opposed to trying to learn whole words in medical terminology, you're going to be a lot better off, because then you're going to be able to piece together words so that it's not so difficult. I always get those requests for books. Well, Blue, what books do you suggest for medical terminology? Something that's easy. Somebody said, suggest me something that is easy. Okay, as easily as you could say to me that, you could easily Google easy medical terminology book. And I'm sure you'll see a ton pop up. But it is about learning to do your research. All of my recommended books and everything are in the description box of all of my videos, and I have links to the independent study video, which it has all of my suggested books in there as well. So yes, the next says, yes, Blue, and every physician documents differently. Truer words were never spoken. Hi, Miriam. Thank you for joining me. Hi, Ellie. Thank you for the blue hearts. Hello, Blue. We miss chatting with you. Take care and enjoy your day. Oh, thank you. Yes, I have missed chatting with you guys too. It's 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 such a it's so weird how you get into like a routine of doing something, which in the evenings my routine is okay, 7:30 p.m. I've got to be on. I'm doing a live and being here and chatting with all of you, and then just a week where I change that up, I'm like, I feel like I'm forgetting to do something. What am I forgetting to do? And it's, not being here. And I will go back on the other premieres. I've gone back and looked at, the comments and everything that were coming into the chat. And, it's so nice to see people are still saying hello. And yeah, I just, trying to make sure that I keep up with everything. But, I wanted you guys to still have content to watch when, during the week. And it's not just that I'm not here, so I'm not putting anything out. I've got to put stuff out, That's the way it works with YouTube. Otherwise, they will forget you. um, the next says, physicians also make up their own abbreviations, and that is when the queries come into place. Yes, you cannot just think that, okay, this means this, right? It has to be clear. And I have broken my providers from this very nasty habit because they were trying to do that. And I asked them, I literally went to them, what is this? Oh, well, no, that means this. Okay. According to this book here, right, which was the official, it was some abbreviations, official medical coding, not medical coding. It was official medical abbreviations for something. I forget how it was, but I said, according to this book, that means this, according to this book. And this that you're using is not on the facility's approved list of abbreviations. So we need to rethink this. Oh, okay. Well, at my last facility, no. You're not at your last facility anymore, sir. I'm sorry. You're here with us. And this is the way we do things. Every facility is different. Some let their providers, okay, well, we'll just let it slide. But it does make for incomplete documentation. And it does get a little scary because think about this. When that patient goes from that provider to another provider, say the same specialty, but in a different location, and that provider has to review those notes, are they going to always understand what that provider meant if they're not using a standard abbreviation? Probably not. And they could always think that it's something else. Well, then now you really have a problem because now what did the patient have? What did they do? What was done to them? So you never want to get into a situation where you're having more than the same procedure done on a patient. Okay, you want to make sure that that patient is being well taken care of. These doctors, they know, but it's always our responsibility to say, hey, we got to look at this documentation. We've got to get it going on the right path. That's what I make a big deal about with my providers. I tell them all the time, when you leave me, I don't know where you're going. I don't know who your coder's going to be. You will always have access to me. Now, some do, yes, some do not. But when you go and you're trying to start off in this new place, you have to give the coder the benefit of the doubt that they're going to try to be there to help you. Number one, not all coders have the same experience. Number two, not all of them are going to pay attention to those details because they're going to think that that's okay in some situations because they've been taught not to question the provider. It's not that you're questioning them like as far as their diagnosis or anything, but it is about making sure that the documentation, that anybody that looks at this can come to the same conclusion at the end of the day. That is the goal, especially of CDIs, or clinical documentation integrity specialists. That is their primary goal, is to make sure that everybody can look at this same documentation and come to the same conclusion. And that is what I've always told my providers. I need to make sure that when these patients leave here and they cart their records with them and they go to this next place and that doctor looks at those records and says, oh yeah, this is this. We understand what this says by looking at what are you giving me. It is about being a teammate with the provider sounding that alarm when things are not adding up, as far as like, okay, we need to have a little bit more documentation here. It needs to be a little bit more clear. Sometimes I would have providers in the very beginning who would be brand new to my clinic, and they would say, oh yes, the patient is 4 weeks post-op, return in 3 weeks. Okay, we have a problem here. What did they have a surgery for? When did they have that surgery? And did you change any dressing? Well, that's just common sense, Blue. They're going to have their dressings changed. Okay, yes. But I don't know. I wasn't in the room with you when it happened. So what surgery did they have? Okay, well, they had an ORIF. Oh, okay, now we're talking. So they had an ORIF. Why do you do an ORIF? Well, because they fractured themselves, Blue. Why are you asking me these questions? Because this is what I'm missing from the documentation, sir. This is what I'm missing. Oh, it's a completely different diagnosis code. It's a completely different thing that you got to be able to use here. Well, isn't it orthopedic aftercare? No, it is not orthopedic aftercare when it involves an injury. Oh, okay. So making your case as far as like, this is why, is not going to be orthopedic aftercare anymore. When it involves an injury, it is going to be the injury. And then you wouldn't be picking up the dressing changes or suture removals. And even if they weren't operated on, you still would not pick up the suture removals or dressing changes, because when a patient is injured, it is considered an inherent part of treating an injury, is that you're going to change dressings and you're going to do suture removals. That's just a part of it. That's why those Z codes are not picked up in conjunction with the injury codes. Clear as mud, right? Provider communication is everything. Yes, yes, yes. Do you have a website, Blue? Not one that is mine, but I have a Patreon and I have a Facebook page, right? So I just made a Facebook page because everybody wanted me to do a Facebook page. So I do have a Facebook page now. If you go on Facebook, you can type in Medical Coding with Bleu Facebook page and it'll pop right up. I also have a group on there. I don't know what to do with this, guys. You know, somebody had suggested, oh, well, you should teach medical coding and you should give tips on your page. It's a little hard to do or want to do when you guys don't want to watch. I've done the coding like lessons and stuff like that on YouTube, and that is some of the lowest views I've ever had on any of my videos. And so it's like so much work goes into it, but maybe, I don't know, maybe if it's written down, maybe it'll be different and people will want to see that. So maybe I'll just do it to give my Facebook page some sort of content. But I don't know. I'm still trying to decide, and I'm still trying to learn it too. So I had resisted Facebook for so long, but you know, people are wanting it, and you guys are going to get what you want. So, you know, if you watch and that's what you want, and that's what I do. But yeah, I don't have a website page for myself just yet. Although I probably do need to get one of those. That would be helpful, especially for like scheduling, like the tutoring sessions and things like that. That would be very helpful for something like that. Tabitha says, I am starting a entry remote coder position, working remotely in a couple of weeks. I just got my CPCA a few months ago. How are new coders trained remotely? It depends on the facility. They're going to know, because obviously you have your CPCA, they're going to know that you're new. So a lot of yours is probably going to be done virtually. I have heard of some people who get started, who get hired to do remote, right? But they have to do training at the facility for a few weeks, and then they send you home to work. Obviously, that would be a question for your new employer to do. But when it comes to the coding part, they are going to be expecting you to already know how to code, the fundamental basis of coding. But if you are asking a question like, okay, I'm kind of unsure about this, then that's something different. But if you keep asking a lot of questions, you know, they might kind of think, well, was this what we should have done? Should we have hired somebody who was very green and didn't have experience? we need to get somebody in there to help them, so try to do a lot of the research on your own first before you go and ask questions, because I have seen brand new medical coders. I worked with one. I wasn't on I wasn't a medical coder very long. I had been a medical coder maybe 6 months, and they had a new person coming in, and they said, well, okay, Blue, you can help her. And I'm like, okay, I'm just as new, but okay, I'll do my best. And she asked questions constantly. She never wrote anything down, which irritated me, because then you're not really considering my time and you're asking the same question. And I am very patient when it comes to teaching. When it comes to teaching, yes, I will take the time and I will run things over and I'll repeat myself and I will do those things and I'll do it with a smile on my face, because that is what I do. I think about how I would want somebody to teach me, right? But when I saw that she wasn't doing it, it irritated me enough after a whole week. She'd not been answering. I mean, she had not been writing things down, asking the same questions over again. And I finally told her, I'm going to have to stop helping you if you do not write this stuff down. I said, because we've been going over the same thing. Oh, I know, Blue, but I just don't understand. If you don't understand, then you need to let me know why you don't understand. Because I can't read your mind. I failed mind reading 101. I'm pretty good at energy, but I failed at mind reading. So, but yes, that is one thing I would suggest, is that you write stuff down, make notes, and make sure that you're doing your research before you go and ask questions. At least that's just my advice anyway. Jessica, my coworkers never query uncontrolled diabetes because the providers always give us a hard time about it. I get some providers that are great about answering queries and others will just ignore me. So it really does depend on if you're in the facility or not. If you are in the facility, then sometimes the emails kind of need to take a back seat to actually going over there and sticking your head in and saying, hey, how you doing? Let's talk about these uncontrolled diabetes. Hey, let's get with the clinic administrator and let's do an in-service, because we still have this problem. Uncontrolled diabetes is a serious issue and it needs to be appropriately coded, right? Because when you're thinking of all of this data that's getting collected, right? And all of a sudden you see this whole population of diabetes is no complications, but actually there's a lot of complications. There's funding that goes into it. Not that you're doing it for money or anything like that, but there is actual reasons why this stuff is important. In the state of Colorado, they did a study, right? I heard about this a long time ago. They did a study about why people were getting so many spiral fractures, right? Spiral fractures happen when you're skiing, right? That is because it's high velocity, high impact, and that kind of thing. So a lot of spiral fractures were being seen in the state of Colorado alone. And how did they get that information? Well, because the coding had to be appropriate in order to see this huge spike. And okay, this is a spiral fracture. Okay, we've got a lot of patients who have spiral fractures in this area. Let's do some public education. So there was a public education campaign out about safety. And there's a lot of things that happened because of this, because of good coding. So this is a two-prong approach. It is you actually being there, if you are there. I know that sometimes it's not possible because we're in a half breed area type time of COVID, half COVID, not COVID. So if you are there in the facility, it is a good thing to go and start building those relationships with those providers. Now, I've talked about my candy basket all the time, right? Candy basket. It doesn't have to be expensive, but sometimes these providers, they're hungry, they don't realize it, and sometimes they get snappy. A little bit of sugar never hurt anybody, right? So I have learned that has worked for me. Like I can get them to calm down when they see that I have candy with me. They're like, oh, okay, well, she's not so bad after all. Well, then you get them to relax, and then you can start to explain to them why it's important. So how you approach them has a lot to do with that. If you are approaching them in a gung-ho manner and you're like, you will do this and this and this, and I'm coming after you with my red pen, they're not going to like that. Okay? Providers do not like that. They don't want that. How dare you I'm a doctor. I've been to school for many years. And what are you and who are you? It is about saying, you know what? It's not about that. We're teammates. We're teammates. I'm here to help you, man. That's all. That's it. I'm here to help you. And sometimes they'll resist you in the beginning, and then other times they want to see what you're made of, and they'll resist you. Oh yes, I had a podiatrist who did this to me. He would tell me no, and he would scream, I never had to do this before. Why do I have to do this now? And no, you're trying to make me work harder. I said, no, actually I'm not. But I see that you're doing this because you're telling me this, and this. And it's not coming out of the documentation because you aren't documenting this specificity or whatever, because it's there, but it's not specified. So it's just like, okay. I said, but it's entirely up to you. And finally I was like, you know what, after 3 months of this and going back and forth where he's just screaming because he doesn't want to answer queries, he doesn't want to respond. Okay, fine. And I went to him and I said, okay, you know what, you win. I'm defeated. Whatever you have there is whatever you're going to get. If you absolutely feel that this is not important to you, you do not want to do this, that is fine. I will do this. I have tried. I've done everything but cry in front of you to get this right. I said, but I'm just trying to do my job too. And I said, but I will respect what you say. You don't want any more queries? Fine. Then whatever you have there is whatever you'll do. Whatever you'll get. Really? Yeah. Whatever you have there. And I said, if it pains me that I know personally that this documentation could be better because what I see. But if you want low levels, that's fine. That's fine. Because at the time, we were going through the points system, right? And he refused to meet those points. And I'm like, okay, well then if you don't have like all of your history and physical, and I can only give you up to a level 3, when actually it should have been a level 4 because you had decision for surgery and this is a complicated patient. But you want to only do a level 3, okay? Okay. And wouldn't you know, the next week, I started seeing a huge change in his documentation. And I said, this isn't the same doctor. This is no way this is the same doctor. I started looking at it like, are you serious? He started using templates. He started going to his colleagues who didn't have this problem, because they were working with the templates, so they knew what questions to ask as far as like, okay, this is, I know I need to have this, I know I need to have this, I know I need to have this. And it wasn't so that they met those levels, it was so that they had complete documentation to be supportive of a decision for surgery, okay? Because I told them, I said, if your visit is straightforward and you're doing a 4, I said, that's inappropriate, okay? It needs to be decision-making appropriate. And so they understood that, and so he went and redid, and he started using his templates. He redid his template thing, and all of a sudden I started seeing a lot better documentation. I'm like, okay. And then he comes by my office and he says, did you see what I did? I go, I actually did. He goes, the reason that I did it. And I said, no, I don't. And he's like, well, I can't just do what you tell me to do right away, Blue. I said, are you serious? Like, really? I had to go through all that? He goes, I didn't know what you wanted. And I was like, I was clear. But I'm not going to complain because you did fantastic. And he is amazing. He is literally one of the best providers I have now. And I see everything that he does. He documents fully. He documents appropriately. And I'm like, perfect. So, and he's just says, well, he had to do it that way. No one's ever challenged him. No one's ever tried to work with him. He says I was the only one who's ever done that. And so he turned it around. I said, well, okay. But yeah. All right. What did I miss? All right. Hi, Mitney. I'm doing great. Thank you. The next says, Bleu, you are full of coding knowledge. Thank you for sharing, and I'm interested in your tutoring. Oh, okay, cool. Yes, I'm going to put my contact for the tutoring, in the description box below, so that way you can reach out if you're interested when I update the video. Bray says, just got promoted to coding denials, from coding denials to auditor. Any advice, Blue? Think about how you would like to be told that you're wrong. Think about that. And accept the fact that you're going to be an educator. Accept the fact that you are going to be yelled at. Accept the fact that there are going to be people who resist you. But it's not anything to be discouraged about. A good auditor is going to have an impact on a coder for years to come, right? Because they can actually teach them. If you are somebody that is trying to be like, well, no, I'm right, because I'm the auditor. If you're somebody that's like that, you're going to get a lot more people that are going to resist you. And the quality of the documentation that comes out of a particular facility really does lie on the shoulders of the auditors. Because if the auditors are not catching errors that they should have been, right, then that facility can have a false sense of, okay, well, you know, we're doing really good. But if you have somebody in there who is sharp and who has been studying and who has been going over and reviewing coding clinics, reviewing the the American Hospital Association coding clinics, and been reviewing the coding guidelines and been reviewing new things that come out, and not just being like, okay, no, this is the way that I've always done it, so I'm going to do it this way. When you have somebody that does that studying, that is really going to shine through, and that is going to help your coders more than you know. And don't ever think that just because a coder is brand new that they don't know, because sometimes they do know. Sometimes you'll see that, yeah, they're a little green, they need a little work, and yes, you had to correct them. But sometimes that new coder is right. And I've had so many auditors tell me, oh, no, you're wrong. When I was a CCA, brand new, less than a year. And they were like, oh, no, you're wrong. Somebody else had to come in and break up that argument because, oh, no, she's actually right. So listen to the people that you're auditing. Give them the opportunity to present their argument, okay? Never yell, never get excited. If they're getting excited, then it needs to be established that those rules, okay, hey, let's bring it down. You're on a 10, let's get to a 2. But the more even-keeled you can make yourself, the better off you'll be, because somebody that gets excitable is going to lose that audience. They're going to lose the respect of that person as well. So you want to make sure that you are calm, and that if they're telling you, no, you're wrong, and you don't know, and in this and that and that and the third, then you need to say, okay, well, according to this coding clinic, or according to this official resource, this is the reason that this actually is the correct answer. So help them to know. But don't ever think that you're above them, okay? I've seen too many auditors. I've experienced too many of them. And too many of them have a high opinion of themselves, that they think that they know everything, and they actually, if they would stop and reread and look at, then they would know that, oh, okay, well, wait a second. Maybe I was wrong. And it's okay to be wrong. Even I have to admit when there are times when I've been wrong. Oh, okay, I'm wrong. You know, so at least that's just my advice anyway. If you're going to go from that to that, that's just something to think about, look out for. Misty, I think the Facebook page can also be a community for medical coders to be able to come together for all things medical coding, post jobs, share tips and tricks of the trade. Just my 2 cents worth. Thank you, Misty. That's a good idea. I like that. Tabitha, thank you for answering my question. Ellie, I'm studying musculoskeletal system right now. Yay! Christopher. Oh, hello, Christopher. I have seen so many people coming back from ski trips in gas. It's true. It happens. Think about it. That high speed, you're going downhill and there's ice and snow and woof. This is a recipe for disaster. Yeah, I know. Chrissy says, yes, coding like database for healthcare. We need it. Jessica, yeah, it's been difficult to communicate with providers. I work from home. I try to explain to an attending why it is important to know if a patient is hyper or hypo because she has a prescription for steroids for a diabetic patient. No, I'm not talking about E&M right now. Oh, was I talking about E&M? Yes, I was talking about E&M. I was like, wait a second. Yes, I was talking about E&M. But that was back then when you had to meet certain levels, like on your new patient E&Ms, you had to meet that particular the history and the exam, and then it had to also have a complete PFISH, past family social history, and if they were missing any part of that, they were being dropped. They could not go past a level 3, 99203, because it was missing that part of that PFISH. So it was just like, guys, it's family history. All you have to do is say, did you review it? Is it pertinent? Yes or no? That's it. And so a lot of it was like, well, no, I'm going to resist just because I can. Okay, you're going to resist. It's going to hurt you. It's not going to hurt me. I'm still going to code what's there. I am not sacrificing my credentials because you want to tell me that this is a level that you want. Okay, then you have to meet the requirements for that level. Now of course it's different with E&M. E&M has changed for the outpatient setting in some instances. With the ER, it's still the same though. But with the outpatient setting, it has changed. It's updated. So they like that, although they were not really sure in the beginning if that was okay. They go, you mean we don't need to document all these points anymore? I'm like, no. And like, y'all are okay to just, write it out and let me know what's happening. So they like that now. Tabitha, is it easier to code with coding books or an encoder as a new coder? The encoder takes some getting used to. I'm not going to lie. When I first started, I used the books because we didn't have encoders. Not all facilities have encoders because encoders are expensive. And while they do help, like with some of the edits and stuff, with going through the encoder, sometimes you can go down the wrong path. And if you go down the wrong path, you can get the wrong code. I'm trying to think of the code off the top of my head. Of course, I don't have my diagnosis book with me. And I told myself, bring your diagnosis book. I brought my PCS book, but I did not bring my ICD-10-CM book. What is it? Coagulation. Yes, it was coagulation. So you have the one that's a symptom, and then one that is a definitive diagnosis. Now, the symptom one is if they're taking something and their blood is not clotting, okay? And they run those PT and PTT tests, the prolonged thrombin time, and it's abnormal. That is a code for that. But if you select the wrong path in the encoder, you will get the definitive diagnosis one for that condition. So that is something to watch out for. When you get to the final code, you can kind of start to realize, okay, yeah, that's not the code I was looking for. So, but if you haven't been a seasoned coder for very long, it can get very confusing. So that is something to think about when you're working with an encoder as a brand new medical coder. But it's split 50-50. If you have a very good encoder that guides you along, then you're fine. If you don't, and it's just sort of there, then it's a little harder to work with, I think, anyway. Hi, John. Oh, long time no see. Thank you for joining me. Tangela, hi, Blue. When it comes to the CPC exam for 2021 for E&M, are they testing for 1995 or 1997, or the new 2021 rules based on the medical decision making? I do not have a credential with AAPC. I have never taken the CPC exam. All I know is what the website says, and it lists all the domains. So I have no idea. I couldn't answer that question for you. I do know that they test on E&M. Now, as far as like what they test on specifically, I don't know. Let's see. Let's check out AAPC website. I assume you're taking the CPC exam. I think you told me that. Okay, the CPC exam breakdown. Passing the CPC exam requires you to correctly answer a minimum of 105 questions from the series below. The exam questions, however, will not be identified or sorted by the series to which they pertain. The CPC test will rely on a level of understanding that enables you to identify the series. 10,000 series, 20,000 series, 30,000 series, 40,000 series, 50,000 series, 60,000 series, evaluation and management. The E&M questions will assess your coding proficiency related to place of services such as office or other outpatient, hospital observation, hospital inpatient, consultations, emergency department, critical care, nursing facility, domiciliary and rest homes, and home services. It will also include questions directed at preventative medicine, non-face-to-face services, neonatal and pediatric critical care, intensive care, prolonged services, chronic care, transitional care, and case management and care plan oversight. This exam also covers anesthesia, radiology, laboratory and pathology, medicine, medical terminology, anatomy, ICD-10 CM diagnosis, HCPCS Level 2, coding guidelines, and compliance and regulatory. 5 questions on compliance and regulatory. 5 questions testing your knowledge of compliance and regulations will pertain to services covered under Medicare Parts A, B, C, and D, applying coding to payment policy, place of service reporting, fraud and abuse, NCCI edits, NCD/LCD, HIPAA, ABNs, and RVUs. So that is what is covered on that test. Okay, I'm glad I answered your question. The next. Bray says, thanks, Blue. Absolutely, no matter what role we have, we are constant learners. I'm excited to learn and educate our providers. I'm excited for you too. That's my most favorite thing to do. Drea says, hey, Blue, is there a difference between the CIC and the CCS? AAPC tested on MDM. Okay, so the CIC is a certified inpatient coder, and that is a exam offered with the American Academy of Professional Coders. It's just covering the inpatient side. The CCS is with the American Health Information Management Association, and that test is considered the mastery of not just the inpatient setting, but the outpatient setting as well. So there is a huge difference. It is completely different. You know, one is covering both inpatient and outpatient, and that is the mastery, that is the CCS, the Certified Coding Specialist. And the CIC is just covering the inpatient setting, Certified Inpatient Coder, and that is offered with the American Academy of Professional Coders. So yes, not to compare one to the other, because there's really no comparing one to the other, you know. Did I miss a question? No? I guess it didn't. Okay. All right. So, but yeah. Pretty lively question tonight. Thank you all for being here. Appreciate that, especially for a Friday night. things just take time, guys. It really does. Whether you've been a veteran or whether you've been, in it or not, or, it does take time. I mean, everything takes time. You can't be impatient with yourself, and you can't want to skip over any of these subjects like medical terminology and anatomy. Sometimes I think people get upset at me because I tell them they need to work on their medical terminology and anatomy. It's the best way for you to understand what's actually happening in the record. There's no way for you to get around that. None, other than doing the heavy lifting and actually reading those things for yourself. Yes, I am. I am drinking coffee, John. How did you know? Tabitha, what is your favorite area of coding? Inpatient, outpatient, OB, radiology, etc. OB. I will do OB. It's not my favorite. I like outpatient. I have been working on inpatient. It's different. Inpatient is completely different. Outpatient has been my home, my coding home for many years. Okay, it's been my coding home. So I've done prophy, I've done same day surgeries, I've done clinic coding, I've done the ER. So it's where I feel most at home. It's where I feel most confident because that's what I've done the longest, right? But with inpatient, now that I'm working with it, it is a challenge because you have to think about like the procedures, and you got to think about the approach and the reason why they're doing this. And so that plays a lot of fun for me into that challenge. I don't know enough about it yet on the inpatient side to rule out yay or nay. But I will say that I do like the straightforwardness of the CPT manual on the outpatient side. I do, because it is, to me, when I look at all the codes that are in the CPT manual, they're already put together. There is no messing up one letter like in the inpatient side, right? When you're doing the ICD-10 PCS coding, where you can get all of the letters correct except for one stinking letter, and it's just like, ooh, it's enough to drive you nuts. But then when you see yourself make that transition to like really learning it and grasping it, then you're like, oh, well, okay. Anytime now I know I see total in the thing, I'm looking at a resection, right? That's what I'm looking at in most instances. So I'm like, okay, like total removal, I'm looking at a resection. So that is something that is helping me to understand, like, okay, what's actually happening here? Is this a destruction? Is this a excision? Is this a, is this a drainage? What is this? So that's what makes the inpatient side so fascinating, right? Because it's new. But it's not to say that learning with the outpatient side is ever a closed process, because it's not. Trust me, I'm still learning on the outpatient side. I will always learn. Misty's laughing. But my favorite clinic in coding in the outpatient setting would have to be in ortho and podiatry, because I like the bone work. When you talk about like fractures and setting fractures, and you talk about like all those any kind of procedure that has to do with the musculoskeletal system is fascinating to me. I like those. I enjoy working with those. When it comes to mom and baby, I'm still learning a lot about mom and baby. And again, but if I had to pick my would rathers, I would probably like baby more than coding for mom, because mom is a lot of extra codes. There's extra codes, and then sometimes it's just real straightforward. Okay, good, we got this. But other than that, John, I love coffee. I probably drink too much of it. Probably I do too. I have at least 2 cups a day, although I didn't have any this morning because I was traveling, so I have to make up for it. Yes, so much root operations, but it's fun. Yes, Drea. Yes, it is. Tabitha, I used to be a remote scribe for an orthopedic surgeon and I loved it. Yeah, they say some pretty funny stuff. I like the way that they write. Sometimes I will sit there and look at my providers, the way that they write and stuff. And some of them have, I've had the privilege of working with some that write like poetry. I mean, literally, it's like reading poetry because you get so involved in it. And one of the providers that I've had before, he did really great stuff, really great work, and then it was just like he just lost it all and didn't document like that anymore, and it was just like wow. But I mean, he would have really really detailed stuff, and talking about everything that he did, and it was amazing to read. It was amazing to see, because you don't always see that, you know. And now when I look at some of the other stuff that I see, and I'll sit there and I'll crack up laughing because it's just the detail and how they write, and they write how they speak. And some of them they speak okay, very colloquially, and it just makes it a lot better. And then some speak very abstract, and you're just looking at it like, okay, I'm gonna get the dictionary and let's Google this word because it's like okay, and then my vocabulary starts to expand because it's like okay, I could use this word now, so but that's I don't know, it's for everyone it's different, but that's just one of the things that I look for and when I read and stuff like that, because medical coding is a very solitary field. So you get to know people, like your patients, even though you're not looking at the names or anything. I don't look at the names. I just look at their story. And then you get to know the providers, and you can kind of see where they are. And sometimes you can tell like something's off, right? Because like their documentation will be off and you're like, well, what happened? What's going on? And then other times it's just like, wow, they've really listened to something that I said, or they've really taken some tip that I've done, because I do coding tip of the week. I send them out a coding tip every single week. And it's usually something small, or if I'm seeing something that's a trend and kind of have to remind them, hey guys, let's get back on let's get back in the basket. And they'll look at it and they'll be like, oh, okay. And I can tell that they're looking at my coding tips because their documentation will improve. And so it's just like, so that always makes me feel better. But anyway, you're always looking for those things when you're a medical coder. I'm just saying. Let's see. Missy says, I'm loving your Patreon channel. Oh, thank you so much. I appreciate that. It's so helpful and lots of information in there to boot. I try. Trust me, I try. But thank you very much. I appreciate that. Ellie, right. Maternal with complications should be difficult to code. Yes. It's not difficult. It's tedious. That's what I think it is. It's tedious. It's not that it's difficult. It is just tedious because you have to get, okay, if it's a neurological complication, okay. And then if it is a otherwise specified one complication, yes. And then if it is something about diabetes, and if it is this, and if it's that, and oh, did they have diabetes before they were pregnant? Did they have it after? Is it just gestational? What is it? Same thing with hypertension. Is it related to the pregnancy, or was it before they got pregnant? So it's just like all this detail needs to be there, and you're just like. And you got to get codes for every single one. Yes. Desiree, Bleu, can you speak on the urgency for billers and coders during the pandemic and mass walkouts on the job market? Thank you. Kiara says, how long does it take to become a medical coder? Desiree, to answer your question, they're always hiring. So as far as like walkouts and stuff, this is tiptoeing. People have different opinions when it comes to getting anything related to the shots and stuff like that. So I'm talking about the vaccinations. Whatever your opinion is about the vaccinations is your opinion. Everybody's entitled to their opinion. I always tell people when they ask, about that. Like, well, people are quitting, or, I want to get in it, but, do I have to get a vaccine and that kind of thing? And I'm not really sure about it. I don't really want to do it. Talk to a doctor. Okay. That's what I'm going to say before I say anything else about this. Talk to a doctor if you're not sure. Okay. There's plenty of things even before this vaccine that we had to get shots for. Okay, there's the Hep B, I had to get that, of course the flu shots, and this every single year, with the flu shot, Hep B is like, it's a series and then that's it, so there are things that were already in place beforehand. Okay, I know that this is something that is scary. I mean, people have said all these things about it and things like that, but you really have to think on this for yourself. You can't just rely on your cousin's neighbor's ex-boyfriend's girlfriend. Okay, you can't rely on that person. And there's so many people that are putting credit into that person and not asking the right people. If you have a question about this situation, this vaccine and things like that, and why people are quitting and things like that because it's being mandated and things like that, talk to a doctor. Please talk to a doctor and let them answer your questions. Somebody that is a professional that can help you to understand, because I understand it's scary. I was scared too, but I did get the vaccine. I did, and so I'm fully vaccinated and I'm okay with it. And it's a personal choice, guys, but you have to think for yourselves on these things. Ask a professional and then make your decision based on what you find out. But there's always going to be a need for medical coders and billers, always. And no matter what you hear, that it's going to go away because of AI, artificial intelligence, and that kind of thing, and this or another. They're sending it all overseas, and this and that, Michigas. The thing about AI is it literally has to read the provider's mind. Okay, all providers are going to, and y'all said it here earlier too. Providers are all going to document differently. There's going to be days when they document beautifully and other days when it's just like, what happened? But when you think about this, I mean, it's next to impossible to make a thing that is going to be that detailed, because every single patient is different. Every single provider is different. Every day, every second, every hour is different. So to me, that's not really something to worry about when it comes to, okay, we're all going to lose our jobs because of this. They were threatening that when I started in 2008. And had I listened to that, Michigas, I wouldn't be into this career as long as I have been. So that's what I'm saying, guys. You have to kind of not listen to these naysayers, because you'll have these people who will claim that they know, right? The other medical professionals, you don't want to get into medical coding. They don't pay nothing. Do you know? Are you a medical coder? No, then please sit down, okay? Ask somebody who is a medical coder, then make your decision based on that. But there's going to be people who are going to quit. There's going to be people who are going to be let go for different reasons. There's going to be people who retire, whatever. So there's always going to be this need. And then if you're worried about it going overseas, they've done this. It's a yo-yo thing. It's an ebb and flow. They send it overseas. It has lots of errors. They got to bring it back. Because the thing is, with overseas coding, now it doesn't always happen, so hold your fire, okay? But a lot of times it does. I have seen personally when a foreign-based coding company has had a coder who said that it was a confusion between cardiac lead and lead poisoning because of that one word, L-E-A-D. So that is something to think about. When you have errors and you have a few errors, that's one thing. But when you have a lot that's going to impact that facility's revenue, they got to bring it back and give it to an English speaker who's native English speaking, so that they can read it, they can decipher it. They have to redo it, and they end up paying more money out to get this than if they had just hired somebody stateside to do it. So while some greedy administrators will sometimes try to send it overseas, they're going to bring it right back, because that is a problem with people who English is not their first language. For some, they still struggle because they weren't properly taught English. So they have just enough knowledge, and then they can't really get this, right? But then there are some that English is not their first language, but they are impeccable, and they are actually better than a native speaker because they were taught English properly. So it really all depends on the teaching of the individual. Okay, and this can upset some people. I'm sorry if it upsets your feelings. That's not that. It's not meant to be that way. It's meant to tell you guys the truth. If English is not your first language and you really want to do this, then you need to make sure that you're still studying English. Not just about the medical coding part, but you have to study and get proficient in English on your own. Because when I see a lot of foreigners that try to message me and the message just does not make sense, I cannot imagine having somebody who can't put coherent sentences together sending a query to a provider. So that's the thing to work on. And a lot of people don't want to say that because they don't want to hurt people's feelings. They don't want people getting mad at them. I'm not trying to make people mad. But at the same time, I want y'all to be real. If you are wanting to get into this field, these doctors, they expect you to be proper. They want you to give them proper queries and everything like that. If not, they will not pay attention to you. And it is so important because think about this. This could be your medical record. Your medical record. Would you want somebody who does not care and who is just going to throw together a query if it needs to be queried to get better information? Or would you want somebody who actually cares and who's going to take the time and write things out properly? Something to think about, right? It's just my advice anyway. Kara says, how long does it take to become a medical coder? I tell people study for 9, 12, or 18 months. Some people think that you can get through in less time. There's a lot of schools out there that try to do these really fast-paced medical coding programs. I tell y'all not to do it because it is not helpful. And especially when you're trying to learn something as serious as medical coding, it is not meant to be a joke that you can learn in just a few days or even a few months, all right? You really do need to take the time to learn this if you want to be successful in medical coding. 9, 12, or 18 months is what I recommend personally. I did have somebody who messaged me. They were a medical professional, and they said, well, I've been able to pass through this in 2 months because I'm a medical professional. Okay, good for you. Doesn't mean that you understand fully what's happening, right? If you're going through a program and you've just flown through it in 2 months, and because you have a medical background already, you think that it makes you, that you're going to get this. But when you get out in the real world, it's going to be a lot different. Okay, so let's just slow our roll. Because even if you do have medical background experience, it does not necessarily mean that you're going to be able to grasp it all right away. That's my advice anyway. Ellie. Oh, you're welcome, Ellie. John, I had COVID. Not a fun experience. Oh my goodness. I am so sorry, but I'm glad that you're here with us and you're still making these comments and letting me know, and thank you for sharing. Tangela, I had a friend walk out on her job because she didn't want to take the vaccine and was front end registration. Fully vaccinated here too, Misty. Okay, that's awesome. Hi, Adrian. Christopher, I had COVID and had the antibodies to prove it. That's awesome. Misty, so true. Jessica, it took me 3 years to self-study and get my CCS and CPC. See, there you go. So everybody has a different path, you know. But yes, it's when people think about your job, you know, when you think about your work, and you know, sometimes it's just so scary. You don't know who to listen to, and I get it. But like I said, if you go to a professional, medical professional, not your next door neighbor's cousin's ex-boyfriend's girlfriend, and you ask them to talk about it with you, a lot of times they're going to be able to explain things in a way that can help you to understand what this is actually doing. Because I had those thoughts too in the beginning, like, what is this going to do? What, you know, I had all of these thoughts running through my head, but then I had to think about it. I am my sole caretaker. I have no family to help me. If something happens to me and I get sick, it's all on me. It's all on my shoulders. I am single. I am by myself and I have no family. So I had to make this decision for me because I already have asthma. I was diagnosed with adult onset asthma. And that's scary enough because I never had asthma in my whole life. Never had anything. And then it was just a few years ago that I got diagnosed with it. And so it's very scary to go through this, but you have to make those decisions on your own. And it took me, having these conversations with medical professionals to say, okay, Blue, this is your options, and this is what this does, and this is what it's going to do to your body. Oh, okay. And see, having that, it helped. It helped because it made the decision for me so much clearer, because it was just like, okay, well, if I don't do anything, and if I have this and I work in a hospital, and I can't work from home. I can't. And it's just like, what do I do? So for me, knowledge is power. So it wasn't going online to see all of this stuff, because you have a lot of people who have different reasons for saying things that they do. They have their agendas and they have all of these thoughts, and sometimes they have this misinformation and it comes from somebody that they trust, because they have their own agendas. So because of that can change somebody's path so much. So again, thinking about all of these things that I had to go for myself, and I'm like, okay, well, I need to be here. I need to be here because there's a lot of things that I need to do with my life. And it's not just my work. It is here with all of you too. Because believe it or not, these videos are going to go on in perpetuity. They are. But I would like to be able to touch a lot of people and give them the truth with medical coding and what it's like and being here, and this is my life and this is what I do, and this is what I enjoy. Because I think when you enjoy something and you share this with people and they get that energy from you, and then it can make them think, okay, well, maybe this isn't so bad after a while. Because sometimes people think, oh, well, I'm getting into this because it sounds like a really good field and it sounds like a good field for me. But do you ever really enjoy what you're doing? Are you allowing yourself to enjoy really your profession? Because some people will go their entire lives thinking, oh, well, I don't, it's a job and I don't really enjoy it. Can you imagine that? Can you imagine getting to the end of your retirement thinking, God, I spent 20, 30 years doing something that I really didn't like, and now that I'm at the end and I'm in my retirement years and I'm just going to do whatever? And instead, I can look back when I get to that retirement age, which I don't think I'll ever retire, just to be honest with y'all. I can get back. I know I can get to that time. And I know I can say definitively for me, I've enjoyed everything. Even on the days when it's just like, I've enjoyed it. I've enjoyed my journey with this. And I've helped people along the way. Because that's my way of giving back. This was a gift. I got into this through the employment office because I was unemployed, and they gave us the opportunity to go back to school, and they said, we'll pay for your retraining, but you just have to get a job in the field that you were trained in. And I'm like, okay, I'm all for that. You're gonna pay to train me? Okay, I can go to school. I can do that. There was a lot of people that walked out on that. They're like, I don't want to do that. But I stayed. So this was a gift, guys. This was given to me. Okay. And now here I'm giving it to y'all. Because trust me, there was people that told me, well, I didn't know about WIOA, the Workforce Innovation and Opportunity Act. I didn't know anything about it. And they were able to get into it. So it's making an impact on their life. I'm just saying. Oh, thank you, Veronica. She says, hi, Blue. I'm so glad I subscribed to your channel. Christopher, I've seen college-educated people who cannot put together a coherent sentence. And that is very true. That is so, so true. Adrian, I'm enrolled in a 12-month course, how much time should I dedicate to medical terminology before progressing into medical coding and billing? And thank you for coming in tonight. Oh, you're welcome. Well, I mean, it depends on how long that book is or how long that section is. Look at how many modules you have and break it down that way. And if you're going to go through it in 4 weeks, that's fine. If you're going to go through it in 6 weeks, that's okay too. Just try not to make it any faster than that. You'll still have time to come back and cycle back to it. But if it's self-study, there's going to be certain sections that you're going to go through a lot more faster than others. And it is possible to make it through in 9 months. But I mean, to me, if you're going to take the time to learn medical terminology, just look at however many courses you have and break it down based on the months that you have to do them. Okay. And just try not to rush through anything. And if you feel like as you're getting through the medical terminology portion, if you feel like you need more time than 6 weeks, you want to go 8 weeks, that's totally fine too. It's a little long, but it's okay because you still have plenty of time to make up for everything else. This is my advice anyway. Misty, oh, Blue, I'm so sorry to hear that, but you have all of us, so thank you. I appreciate that, Misty. Tabitha agrees with Misty. Oh, thank you. John says, I have seen people do what you did with WIOA. Always good things. Yes, because it's a blessing. It really is. It really is. And you're welcome, Adrian. Christopher, my working life is a long history of jobs that I dragged myself to. So you get it. You understand. You totally get it. When you don't truly love what you do, it shows. And that can affect the people around you. When I go to work and when I came back, let me just tell y'all that, right? So when I came back to work after the 5 miserable months I was at home at the beginning of the pandemic, right? And I finally came back to work. I was so happy to be there. I was so happy to be there. And the providers are telling me, Blue, it's been so long since we've had your energy in here. So happy and bubbly. And am I always happy, bubbly every day? No. There are times when I've got a lot on my mind and I'll get really quiet and I'll be pensive and just like, okay, hold on, I got to think about this and think about that. And they'll be like, are you okay? You're not your normal self. But then I'll bounce right back because I mean, I'm human. That's what I do, But when they see me and they see that I bring that energy and they love the energy because that is what I do. And I tell them being here, is so much better for me. I thrive on that chaos because when I was working at home, it was so quiet. I'm like, it's so stinking quiet. I had to turn the TV on because just the quiet was getting to me. And I'm like, I was so used to the, knocking on the door, hey, Blue, I have a question. Hey, Blue, hey, Blue, hey, Blue. And I'm like, okay, that's what I'm used to. And that's how I was able to work. But then, I could not work with it being so quiet. And I got a message from my boss. She's like, Blue, are you working? You only did. I was like, oh, I am. But it's hard. It's not something that's easy for me. I don't have 100 people around me like I'm used to. But, that's. But yeah, you want to get into things that you enjoy and look for the things that you like about your work rather than drag yourself to work. At least that's what I'm saying anyway. Misty, I actually looked up the time frame for medical terminology and it says around 2 months. I hope this helps. So see, there you go. 6 months, 8 weeks, that's fine, to do medical terminology because it is a lot. And remember, learn your prefixes, your suffixes, and your root words. All right. So I am out of coffee, and we have gone on very long. An hour and a half, y'all. So I'm probably going to go ahead and call it a night because I see a lot of y'all are starting to leave me anyway. So if y'all have enjoyed this, I hope you hit that thumbs up button. Subscribe if you haven't already, and I will, Monday will be pre-filmed again. Yes, I think Monday will be pre-filmed. If not, I will be here for live. Not here, but back on Monday. I have to think. But I think Monday's going to be pre-filmed. So be ready for that. And like I said, if you're on Facebook and you want to like the Facebook page for Medical Coding with Bleu, that would be great. Because there's 22 people on there currently. But anyway, I'm going to go ahead and wrap this one up. Thank you guys so much for joining me. I've enjoyed this conversation tonight. And you're welcome, Jessica. She says, thank you for this live video, Bleu. Hope you have a great weekend. And y'all too. And I will see y'all on the next episode. Bye.